Hi. My name is Margaret Comeau, and I wanted to start by thanking the Lucille Packard Foundation for Children's Health and Dr. Pan's staff and Dr. Pan himself for inviting me to share some time with you this morning. Thank you all for your time in being here. I am going to speak a little bit about There we go. I'm going to speak a little bit about children with special health care needs in Medi-Cal and the California Health Benefits Exchange. This is going to be sort of a 30,000-foot look at Medi-Cal and the exchange, and I just want to give you a little bit of background around Medi-Cal and its importance to kids with special health care needs, and also what could be important to kids with special health care needs in the upcoming exchange. So Medicaid matters to all kids, but it's especially important to children with disabilities and special health care needs. I want to note here for just a second that there are two different definitional terms that we're using. Kids with special health care needs is what the folks that we've been talking about to this point, and Dr. Bethel talked about the Maternal and Child Health Bureau's definition of children with special health care needs. That's that broad spectrum of kids. Kids with disabilities are those with functional limitations. Things associated with their health that keep them from doing the kinds of things that children typically do: walking, talking, going to school, learning. So children with disabilities and special health care needs are covered by Medicaid in all states. It's particularly important because it offers comprehensive and affordable health care coverage to low-income children and some moderate-income children who don't have access to private insurance, whose families can't afford the premiums or the out-of-pocket costs associated with private insurance, and or who need services not covered by private insurance. So why focus so broadly today on Medi-Cal? It serves children with special health care needs who don't meet the CCS criteria, which is the safety net program that Dr. Wise and other speakers have spoken about, and also because it's the primary vehicle for alleviating the family impacts that Bernadette spoke about. She mentioned that in California, 24.2% of families experience financial hardship as the result of their child's special health care needs, and 28% spend $1,000 or more on their child's care. There are issues related to fragmentation, and there are also issues in Medi-Cal related to low reimbursement rates, but I want to focus today more on the positives for kids with special health care needs in Medi-Cal and give you some basics, really sort of a 101. This is a breakdown in California compared to children with special health care needs in the United States based on their insurance categories. So you can see that in California, more children with special health care needs have private insurance than the national average. Fewer are enrolled in Medicaid or the Healthy Families Program, which is being moved into Medi-Cal currently. Why is this happening? I don't know without doing much more extensive policy analysis than I've had time to do to this point. But I think it's important to note this in the context of the exchanges. So private insurance is important to kids with special health care needs in California, as well as Medi-Cal. And we're going to talk a little bit about the exchanges in just a second. The statistics for kids with private insurance as their primary source of coverage, and Medicaid, Medi-Cal, as supplemental coverage, and kids who are uninsured, they're roughly the same as the national average here in California. So many of you are probably familiar with Medicaid, and in California, it's called the Medi-Cal program. It's a state-federal partnership that is jointly funded. Here in California, the FMAP, the Federal Medical Assistance Percentage, the amount of money that the federal government kicks in for the program is a 50-50 split. So the state pays for half the program and the feds pay for the other half of the program. It's a state-administered program with a lot of flexibility under federal guidelines. So the feds sort of set the stage. They set the minimums for how the Medicaid program operates in the individual states, and then there's a lot of flexibility for states to decide how they're going to go above and beyond that, and if they're going to go above and beyond that. So it is truly a state and federal partnership. There's decision-making, policy-making that's jointly done by the feds and the states, but there's also this funding split that's important. the most recent data I was able to find is for fiscal year 2009, and for children in Medi-Cal, not just children with special health care needs, but children in general, 40% of them enrolled in Medi-Cal, but they accounted for 18% of the spending. So really, when you think about a lot of kids being enrolled in the program, but in proportion to spending on adults, it's a much smaller percentage. You're really thinking about, and with half of the program being funded by the federal government, you're really looking at Medicaid as an investment in low-income children's health as being a bargain. There are 4 basic criteria around eligibility for kids. The first is financial need, and that's the most typical pathway to coverage through Medicaid. Here in California, it's family income under 250% of the federal poverty level, and I'm using that statistic because it's based on the Healthy Families eligibility, so that those kids are moving into Medi-Cal now. It's also based on medical need. For example, if a child is enrolled in the Supplemental Security Income Program by the Social Security Administration based on functional disability, then they qualify for Medi-Cal coverage. There's another group of kids who qualify for Medi-Cal because they have an institutional need for care. So these are kids who you could consider easily, based on their medical necessity, being cared for in an institutional setting, in a pediatric nursing home, in a hospital. One way to come into Medi-Cal is through a waiver program. So these are kids who would qualify for institutional care, which Medicaid covers. Medicaid covers long-term care services in all of the states. But one way to come into the Medi-Cal program is through a waiver, so that a child who meets that institutional level of care but who could safely be cared for in the community by their families at a less expensive rate can come in through a waiver and get the Medi-Cal coverage that they need to keep them out of an institution. Finally, kids with out-of-home placements, like children in foster care, the overwhelming majority of kids in foster care are eligible for Medicaid. And so that's a way of providing continuity of coverage for them. It doesn't always work that way, and there are significant challenges around making sure that kids not only have coverage who are enrolled in foster care, but who also have access to actual medical care itself. Medical coverage is incredibly important. Insurance is incredibly important, but it's only a gateway to healthcare coverage. It doesn't automatically assume that you're getting the care that you need. So I think that's an important point to note. I talked just a little bit ago about the feds setting the basic guidelines for the Medicaid program and how it operates. And these are the covered services that are part of those federal guidelines. So you can see the list on the left-hand side, the mandatory services that every state has to provide within their Medicaid program. There's also a list of optional services that states can decide to cover if they choose to. The one that I really want to note for you today, though, is if we were talking about a Medicaid program that covered adults, then we'd be talking in a little different way. But since we're talking specifically about kids today, the last one here on the list on the left is the most important one: early periodic screening, diagnosis, and treatment. So between these mandatory services and optional services, it's really a comprehensive list of what's available with very strict cost-sharing limits for folks to help protect them from financial hardship. Medicaid is basically designed to serve a low-income population, so the very strict cost-sharing requirements within the Medicaid program are important. But this last service here on the list on the left, early periodic screening, diagnosis, and treatment, is specific to kids under the age of 21 who are enrolled in Medicaid. It's really important to children with special health care needs. When I opened my remarks, I talked about Medicaid coverage being both comprehensive and affordable, and this is where the comprehensive piece comes in for kids. Early periodic screening, diagnosis, and treatment, it's a very descriptive label. Lots of folks rattle it off EPSDT, that's what it stands for. It means early, getting in before sometimes a health problem is even identified, before it has come up and started to cause problems, we go looking for it. Periodic means we look for problems on a regular basis, not just sort of on a random basis, but on a regular basis. We screen for problems, we look for them, we diagnose them, we figure out what they are, and then we treat them. It applies to all Medicaid-enrolled children under the age of 21. Dr. Bethel, in her remarks, mentioned the importance of developmental screening as a key opportunity to increase health status and outcomes for kids. And Medicaid is the only payer mandated to provide this level currently of developmental screening. Part of the ACA has provisions in it around preventative services, and that's going to be an incredibly important way in which kids who are privately insured try to get some of these developmental screenings at better and higher quality. But that's a separate talk that probably will take up more time than we have today. So let's focus back on EPSDT. Age trumps pathway. So I talked about the eligibility criteria for coming into Medicaid: income, medical need, out-of-home placement. Regardless of how you come into Medicaid coverage as a child, if you're under the age of 21, you qualify for EPSDT. So everything that you saw on this list is really basically required for kids. There are really no optional services for kids under Medicaid. Screening, diagnosis, and subsequent treatment are provided even if the service isn't part of the state's Medicaid plan. So any medically necessary service for kids is actually mandatory. The caveat associated with that last bullet point is that there's no standardized federal definition of medical necessity. States have a lot of discretion in how they define it and how they interpret it, so there's a lot of variability between states about what's considered medically necessary and what isn't. For example, services for kids with autism spectrum disorders are covered by Medicaid in some states. They're not in other states because the states have made different determinations about what's medically necessary. So we've talked to this point a little bit about the importance of Medicaid and Medi-Cal to kids with special health care needs. Let's turn our attention to the state health exchanges. I think the feds have started to talk about less use the term state health exchanges and more use the term marketplaces, which to me, it just feels a little bit more conceptually open. You can really consider the marketplaces, the exchange plans, as being a quasi-public benefit program because of the federal subsidies that will be involved in it. They will be opening on January 1st of 2014, so that's not a long time from now. They will be open for enrollment starting in October of 2013, which is really not a long time from now. So there are states who are really scrambling to try to make sure that their exchanges are going to be ready for enrollment starting in about 6 months from now. So there are a lot of challenges that policymakers are facing now in trying to make sure that those are going to be open and available and ready to go. The exchanges are going to offer a choice of different individual and small group plans, and small group is defined as employers with less than 100 employees, and these qualified health plans will be available to folks, including, by the way, child-only plans, which are required to be offered. These qualified health plans are going to offer folks an opportunity. It's really going to open up the marketplace to folks who currently don't have access through the individual or small group markets to affordable and comprehensive coverage. They will include what's called the essential health benefits, which is the comprehensive list of services that are going to be required under the qualified health plans. My colleague, Margaret McManus, is going to talk with you about the essential health benefits in a lot more detail for California. But I just wanted to mention those because they're incredibly important. I think if you think about EPSDT as being the comprehensive piece for kids coverage in Medi-Cal, you could think about the essential health benefits as being a little bit of a corresponding child benefit package for kids in the exchange plans. They're going to offer help to consumers in choosing a plan. So Bernadette mentioned in her remarks that right now families oftentimes don't have the information that they need to make a good informed consumer choice about their health plan, so the marketplaces are supposed to be designed to help folks make a better choice around that. And they're also going to offer help with affordability. There'll be subsidies for folks with income between 100 and 250% of the federal poverty level, and tax credits for them between 100 and 400%. So in California, the California Health Benefit Exchange is going to be called Covered California. I'm sure there are folks in the room here today who know a lot more about this than I do because you're really immersed in it, you're really involved in it. I wanted to make just a couple of quick remarks about it. It's a state-based exchange, one of 18. The majority of states decided that they would either run a state-federal partnership in their exchanges or that they would have the federal government run their exchange. So California is one of 18 who decided to run their own state-based exchange. It's designed as an independent public entity within state government with a 5-member board appointed by the governor and the legislature. And California was the first state to authorize an exchange after the ACA was signed. So you all have gotten a little bit of a jump on a lot of states who were waiting for the Supreme Court decision and then who were waiting for the results of the presidential election. There are many states that are scrambling now to try to figure out how they're going to run their exchanges. So California has a little bit more time under their belt in terms of thinking through the very complicated issues associated with the exchange. So let's talk for a second about the integration of Medi-Cal, Covered California, and children with special health care needs. So the California Association of State Health Plans estimates that about 500,000 kids are expected to be eligible for coverage under Covered California. That's a lot of kids. 500,000 kids is a lot of kids. And many of them will have special health care needs. The ACA calls for integration between Medicaid, CHIP, the Children's Health Insurance Plan, Healthy Families here in California, and the exchanges, even though there are differences in eligibility. So that's an incredibly important point, too. There'll be a single application. Folks will fill out a single application, and then processes will be put in place to figure out which bucket that individual is eligible for coverage, whether they go into the Medicaid program, whether they qualify for the Medicaid expansion that Healthy Families has evolved into, or whether they'll be eligible for exchange coverage. It's going to be really, really important that there be a plan for seamless movement between them when eligibility changes happen. You know, families get bigger, families get smaller, families change income, they change jobs, they make more money, they make less money. There are all kinds of different things that happen. So there is the risk for churn, which is moving in and out, getting coverage, losing coverage, going back and forth between different coverage sources. There's a big risk for churn associated with this process if there isn't a good plan for them to be integrated successfully. Kids could fall through the cracks, and without coverage, they could miss essential health services. For many children with special health care needs, the health consequences of missing health care access and coverage and care can really be devastating. Their families are at risk for significant avoidable medical debt and financial hardship, and costs go up for payers and for states. Churn is not only onerous and burdensome on individuals, kids, and families, it's also onerous and burdensome on payers and on states. As people move in and out, there are costs associated with taking them off of coverage and then putting them back on. So that's an incredibly important thing, I think, for all stakeholders to be concerned with. It's much better to keep a kid with asthma, for example, on their prescription medications, on good health care coverage, than to be caring for them in the emergency room or through an avoidable hospitalization. So it's really going to be essential that these programs work together to ensure that kids stay covered. This is my contact information for follow-up questions if you have any. Thank you for your time and attention today. I'm going to turn the podium over now to my friend and colleague, Margaret McManus, who's going to talk with you in a lot more detail about the essential health benefits, about the child health benefit package in the exchanges.